be introducing our guest speaker, Dr. Erin Michos, who's from Johns Hopkins, and I thank her profusely for accepting this invitation. Before we have this debate happening, I would like to invite Chairperson Dr. Dhaval Doshi, Dr. Nikhila Panchani, Dr. Poonam Brahmbhatt, Professor Dr. Mahadev Desai, Professor Dr. Naeem Qadri, Professor Dr. Shivani Patel, and we have a very interesting session, American diet, Indian diet, how you can utilize the Mediterranean versus the Indian modification of that versus calorie burning, the three important speakers, and I over to Chair to introduce our speakers. Thank you.
So good evening to all. I welcome all to in this excited session of diet and lifestyle modifications. It is my great pleasure to invite Dr. Erin D. Michos. It is an Associate Professor of Medicine in Division of Cardiology at the Johns Hopkins University School of Medicine, with joint appointment in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health, Director of Women's Cardiovascular Health, and Associate Director of Preventive Cardiology with the Johns Hopkins Center for the Prevention of Cardiovascular Disease. I really welcome Dr. Erin D. Michos, and I invite her to speak on the very good session.
Great. Thank you. I'm not able to share my screen just yet. Let's see if that works. All right, I'm assuming you can see my screen now. So thank you so much for having me here to talk about Mediterranean diet is still the most studied and tested, time-tested proposition. And my only disclosures is that I'm half Italian and I'm married to a Greek. So this is here us in Greece. So I may be a little bit biased. Our case patient is a secondary prevention patient. He's a young man who's already had a myocardial infarction with a stent. He has metabolic dyslipidemia with elevated triglycerides, low HDL, and elevated LDL. He was appropriately started on rosuvastatin, but we know that he needs optimization of lifestyle. So apart from optimal medical therapy, what is the most recommended diet for him? And I will argue it is the Mediterranean diet that has the most evidence from randomized clinical trials as well as observational data. So the US guidelines have recommended 3 healthy diet patterns. The DASH style diet emphasizes more restriction on sodium and has benefits of lowering blood pressure and LDL as well as cardiovascular risk. And the DASH diet focuses on vegetables, fruits, low-fat dairy products, whole grains, lean meats, fish, poultry, fish, beans, and nuts. And you'll see that most of these components are the same, essentially the same components in the Mediterranean diet. The Mediterranean diet, though, has more of an emphasis on nuts, fish, olive oil than other diets, a little bit less emphasis on dairy than the other diets, but has the most evidence really for actually reducing hard, meaningful outcomes like myocardial infarction and mortality. It's a diet that focuses on vegetables, fruits, nuts, legumes, whole grains, olive oil, lean meats, fish and poultry, limits red meats, processed meats and sweets. And then a healthy vegetarian is actually very similar to Mediterranean, except without the fish, really without any meat or poultry products, and focusing on lean plant-based protein. But again, very similar components. So again, here it is again, Mediterranean diet's higher in fruit, particularly fresh fruits, so not canned fruits. The vegetables are really emphasizing the root and green, leafy green varieties as opposed to some of the other starchy vegetables. Whole grains that we see in cereals, breads, and brown rice, fatty fish, the omega-3 fatty acids, a lower end red meat, emphasizing lean meats, and substituting nuts and other types of vegetable oils in lieu of butter and other fats. So it's actually a moderate fat diet. It's not a low fat diet. It's just low in saturated fats and replacing saturated fats with the healthier polyunsaturated fats, and it's high in fiber. So we have known about the benefit of this for more than half a century, really going back to the landmark 7-country study that was initiated back in 1958 by Dr. Ansel Keys, who launched the study. He studied men aged 40 to 59 from these 7 countries. Like, you know, they didn't study, unfortunately, women in cardiovascular trials back then. But he found that men living in countries such as Italy and Greece, countries that were had a diet that was rich in fruits, vegetables, grains, beans, and fish, had a low myocardial infarction rate. And in 1975, he wrote this book, How to eat well and stay well? Well, it's the Mediterranean way. Then 20 years ago, we had this large epidemiology study from Greece that was published in the New England Journal of Medicine. It has followed 22,000 adults in Greece who had filled out a food frequency questionnaire, followed for about 4 years. And a greater adherence to the Mediterranean diet was associated with a 25% reduction in all-cause death, a 33% reduction in coronary death, and a 24% reduction in cancer death. Now, I will be the first to admit that there's a lot of problems with observational studies, nutritional epi. There's a lot of confounding by other healthy lifestyles. You know, it's not just the Mediterranean diet, it's the Mediterranean lifestyle that includes increased physical activity, family social support, reduced stress. So that's why randomized clinical trials are our best evidence. And we have that in Mediterranean diet. The landmark study was the Leon-Hart study, published in the 90s, randomized 605 patients after myocardial infarction to an either Mediterranean style diet or a controlled diet, and was told to eat prudently. And the Mediterranean diet at 4 years was associated with reduction in myocardial infarction and death. So we actually have a diet intervention in a randomized clinical trial that was shown to reduce mortality. That is one of the strongest evidences that we can get. Furthermore, we have evidence from primary prevention randomized clinical trial. The PREDIMED study studied over 7,000 participants aged 50 to 80 at high cardiovascular risk, but no clinical cardiovascular disease, followed for almost 5 years. There was 2 Mediterranean diet arms, one that was enriched with nuts and one enriched with olive oil. But both of these arms, compared to control, was associated with about a 30% reduction in a major adverse cardiovascular event. Now, there were some initial methodology issues with the trials. There was recruitment from family members in the same household. So there was an unfortunate retraction, and then they had to reanalyze and republish. But in the reanalysis, the results were essentially unchanged with the same results. Additionally, observational data built in within the stability trial. The stability trial was studying daraplatinib, but why it's of note, it was a large study, 15,000 patients, secondary prevention, stable CHD, but enrolled people from 39 countries. So this is really broad around the world who had filled out a diet questionnaire, and individuals in the trial who reported a greater adherence to the Mediterranean style diet, particularly with a score above 15, had a reduced event rate for a major adverse cardiovascular event. A couple of years ago, I had the pleasure to work with Dr. Mamas, who's a speaker in your program on this meta-analysis of over 16 observational studies. And we looked at different types of foods, individual food groups, and associated with mortality. And the foods that ended up in green were the ones were associated with mortality reduction. Ones in red were associated with increased mortality, and yellow was neutral. And I know you can't see that, so I want to break it down of what were the foods that were associated with less mortality. And it's the same foods that are in a Mediterranean style diet. It's your root vegetables, your leafy green vegetables, your fish, your whole grains, your nuts. This is a Mediterranean pattern, all associated with reduced mortality. We did find that processed meats and tinned fruits were associated with increased mortality. Of course, this is not recommended in any healthy diet pattern. So I had the pleasure of being on the 2019 US ACCHA primary prevention guidelines, and we did an extensive literature review and making our dietary recommendations. And we came up with that a Mediterranean diet really aligned with our class 1 recommendation. So we gave a class 1 recommendation that there was the most evidence to recommend a diet that emphasized vegetables, fruits, legumes, nuts, whole grains, and fish. And again, that is a Mediterranean diet. We recommended replacing saturated fats with polyunsaturated fats. Again, we're not didn't recommend a low-fat diet, but replacing the less healthy fats with healthier fats. Again, aligning with the Mediterranean diet. Reducing cholesterol and sodium, which would match with DASH as well, and avoiding processed or minimizing processed meats, refined carbs, sweetened beverages, and avoiding trans fats. So in summary, to reduce cardiovascular risk, especially in our high-risk patient, we want to focus on all the ABCDs, but I will emphasize that for diet, we have the most evidence for Mediterranean diet from randomized clinical trial evidence, and that's what I would recommend for our case patient who's at very elevated risk. Thank you for your time.
Over to Chair to introduce our next speaker, and we can take questions at the end of all sessions.
Thank you so much. Very good and excellent presentations, very informative presentations. Now I move on to the second presentations. I invite dietitian Shweta Nagar from Ahmedabad. She is the founder at Vitasia Wellness, the diet clinic at Ahmedabad. She is MSc Foods and Nutrition with more than 12 years of experience in the field of health and nutrition. So I now invite Dr. Shweta Nagar, dietitian Shweta Nagar, for the presentation.
Shweta, need to unmute. You're mute. You're muted.
Am I audible now?
Yes.
Yeah. Thank you, Dhaval, for introducing me, and it's my pleasure to be a part of this conference. Let me just begin with the presentation and jump into the discussion. So, talking about the balanced diet, am I able to share my screen now? Is it visible?
Yes, it's visible. Please go ahead.
Okay, fine. So talking about the balanced diet, when we talk about researches and lot many researches regarding which diet is working. So ma'am has already shared, Dr. Erin has already shared one of the slide which shows that Mediterranean diet is the most used diet for this kind of a patient. But talking about that, I had attended a similar kind of a patient 2 years back. When we are talking about this patient, the focus is on the triglyceride levels as well as the LDL levels and improving the HDL levels. So I want to share a typical case that I handled in 2018. His name is Mr. Dinesh Utwani. He's a typical age, he's a boy, he's a man with 30 years of age, and his weight was 66. He was not an overweight guy, but he came to me with an elevated lipid profile. His lifestyle was little bit active, but the only problem was his biological clock. He was not very much sleeping on time and waking up on time. So that was the issue, and the dietary habits involved high alcohol consumptions with high intake of red meat and non-vegetarian food. The medical condition, as I said, he came with an elevated lipid profile. So this is the typical report that I was shown at the very first day. So that was 5th of June. His triglyceride levels, if you see, it was 717 milligram per deciliter. His cholesterols were high. His VLDL was also very high. LDL, though being in the normal range, it was still on a higher side. So the diet therapy that I applied to this patient was balanced Indian diet with a total calorie of 1500 to 1600 calorie per day, depending on his physical activity and the day-to-day lifestyle, wherein I restricted refined carbohydrates and particularly sugar and liquid food. Fat was as like Mediterranean diet, it was less than 20% of the total calories as fat, and saturated fat was reduced to less than 7%, which was achieved by avoiding trans fatty acids and other fried food. So dietary cholesterol was also limited to 200 milligrams per day. So that could come from the non-vegetarian food, like little bit of eggs, and non-veg like meats and poultry. And I also added a functional Indian food like garlic and fenugreek. There are researches related to garlic and fenugreek, and it has proven that it lowers the LDL levels, and it also reduces the risk to heart disease. So after 3 months of giving a balanced diet, there was a substantial reduction in its triglyceride levels. So from 717 milligram per deciliter, the triglyceride fell down to 187. So this is a comparative, this comparison of before and after blood reports of his lipid profile. Cholesterol was 273, which reduced to 142 milligram per deciliter. 717 triglyceride reduced to 187, VLDL reduced to 37.4. Direct LDL also reduced to 74.4, and there was an improvement in HDL levels, which went up to 39. So basically, the patient that we are talking about right now, if we give them, if we give him a balanced diet, the carbohydrate content should be around 50 to 55%, which is very much needed for the minimum physiological work that the body has to perform throughout the day. That wherein the carbohydrate should come from the this whole grains, and we should replace refined carbohydrates and junk food with whole grains, and we should make sure that there is 3 to 5 servings of fruits and vegetables on daily basis. Protein should include 25 to 30% of the diet of the calorie in a day, which should include dal, pulses, and legumes with milk and milk products. Egg whites are also one of the good sources which you can give, fish and poultry, and restricted organ meats and red meats, as even Dr. Erin said. Dietary modification, when you talk about fat, fat is the very important area when we design the plan for the patient like this. So majorly we need to restrict cholesterol in the diet, which includes groundnut oil, ghee, butter, high fat milk, meats and red meats. All the non-vegetarian diet should be restricted to not more than 2 times in a week. So because all the non-vegetarian food also contains cholesterol in it, so we need to restrict that. An increased intake of food containing PUFA, that is, you should include more of pumpkin seeds, sesame seeds, flax seeds, those kind of seeds as a mid-meal option in the diet, so that the patient receives good polyunsaturated fatty acids. In contrast to olive oil, which is the major hype in the Mediterranean diet, we can replace it to sesame oil, mustard oil, and soya bean oil that hinders the absorption of LDL, and so it is advisable to replace and make sure that the intake, we have to make sure that the intake of the oil should not be more than 20 grams per day, because it also includes the calorie in the diet, and that might lead to weight gain for the client further. Soaked almond and walnuts are also a good source of omega-3 and 6 fatty acids that should also be incorporated in the diet to reduce the cholesterol levels. Other dietary modifications should be around low salt diet to avoid the hypertension, and 2 to 2.5 grams per day is what we should be recommending. Increasing vitamin C levels to maintain the elasticity and of the artery walls, and a normal calcium intake within the recommended daily allowance. Now, talking about Mediterranean diet, as Dr. Erin already said, that it consists of vegetables, fruits, lentils, herbs, nuts, and whole refined grains. It also allows a little bit of dairy and poultry, etc. So in whole, if we see, Mediterranean diet itself is a balanced diet. It is nothing but a balanced diet. The only thing is there are few hitch when we try to implement Mediterranean diet into our culture. There are few hitch which I would like to highlight here. So all the researches that has been shown related to Mediterranean diet are equal to balanced diet, because most of the food that are used in Mediterranean diet are also used in India, right? So few hitches when we apply a Mediterranean diet are the olive oil, as I said before. So your focus is olive oil when we plan a diet plan, right? So in India, it is little difficult when we talk about the traditional cooking methods. The cooking methods usually need heating up the oil to certain level, to the smoke level, and because the smoking point of olive oil is less, we cannot use it in a traditional manner. So that is why in India, if we are talking about oil, the olive oil should be replaced to sesame oil or mustard seed oil or soya bean oil, which can be a replacement to in contrast to Mediterranean diet. Second, the Mediterranean diet also focuses more on fish. Last few slides. So secondly, the fish is something which is also being focused. So in India, fish again is available on the regional basis. So we don't get fish at every place, so we can't include fish on all the time. Second is wine is also one of the drink that Mediterranean people have, but then here majorly people have alcohol and beer, so which is again the problem, and the way they consume is also a problem. So basically Mediterranean diet definitely is a good choice, but talking about implementation in India, it little becomes difficult due to some hitches. So mainly when we talk about planning a diet, we need to successfully take a dietary intervention. We need to understand the culture of the person, and then focusing on the lifestyle modification as well as the day-to-day eating habits. We need to design a plan rather than isolating some nutrients like this. Thank you.
Over to Chair to introduce our next speaker.
Thank you, dietitian Shweta.
Thank you.
Now, I welcome Dr. Shilpi Mohan for the next presentations. She is consultant cardiologist at Apollo Clinic and Ashwatha Cardiac Care Center, Secunderabad. She was awarded by Primetime Research Media as most prominent cardiologist of the year 2019 in Secunderabad. I welcome Dr. Shilpi for the talk.
Am I audible?
Yes.
Yes.
Yeah. Good evening, everyone. First of all, I would like to thank Dr. Kapil for giving me the opportunity to be a part of this debate. With due respect to Dr. Erin Michos, who is a pioneer in this field, I would like to put across my points in favor of exercise over diet modification. Here we have a young post-angioplasty case with a deranged lipid profile with triglycerides, with a higher triglycerides, borderline HDL, and high LDL. His ethnicity is not known, but we presume that he's an Indian patient. Any modality of treatment is better than the other if it improves the quality and quantity of life, if it is logistically less challenging, cost effective, and acceptable to the patient. First of all, I'll talk briefly about the Mediterranean diet. Is Mediterranean diet more studied and time tested in Indian setup? No. So can we replicate the results in Indian setup? That is questionable. It is designed specially for people around Greece and Italy, as mentioned by Dr. Erin. And Indian gut biome may not be able to accept the change in diet. And as highlighted by by another esteemed speaker, Indian style of cooking also doesn't gel with olive oil. Wine is a part of Mediterranean diet and we cannot recommend it to all Indian patients. And is it cost effective? We don't know the socioeconomic status of the given patient, and one bottle of olive oil, 1 liter, may cost more than 800 rupees. So over a long run, it may not be a cost effective solution for our patient. In a modified country, are we ready for a modified Indian diet? Yes, it is easily accepted, I agree, but it is easily achievable. It is a questionable, because India is a yummy country and food is like religion. And the psychological impact of eating less is more than the psychological impact of having a myocardial infarction. So it is questionable whether it is acceptable in the long run. This brings us to my premise: how we burn is more important than how you earn. And in my discussion, I'll not restrict myself just to what is classically known as physical exercise. And in my subsequent slides, I'll discuss about yoga, right breathing technique, and how to time right so as to burn it right. It is time tested, we all know that. It has been prescribed by Shweta from India, Plato and Hippocrates, to name a few, and in their respective eras. Not only that, I want to highlight that Dr. Erin Michos has herself written an editorial in JAMA where she has highlighted the importance of physical activity and its benefit in cardiovascular health. I would like to quote, "Some is better than none and more is better yet," unquote. I came across another article, 10 things to know about 10 cardiovascular disease risk factors, where Dr. Erin has authored the physical inactivity section. And besides the other point where she has highlighted the importance of physical activity, she has mentioned the metabolic benefits, which is especially important in Indian setup, where she has shown that it improves insulin sensitivity and it improves the triglyceride control and better HDL reduction. With the evolution of mankind, it seems that we have devolved from Homo sapiens to what is now known as which will now be known as Homo offices, because of the sedentary lifestyle. And exercise plays a holistic role in the well-being of the patient. We cannot expect this kind of a change with the change in diet, whether it is modification or change to Mediterranean diet. Now, let me highlight what all benefits I would like to derive in my patients with exercise. There will be a definite reduction in triglyceride, increase in HDL level, improvement in insulin resistance. There will be better myocardial regeneration, collateral formation, decrease in sympathetic tone, reduction in inflammation, and last but not the least, the psychological impact of exercise in my patient. Indian atherogenic dyslipidemia differs from the best, we know that. Because of the high carbohydrate intake, we have elevated triglyceride level, low HDL level, and borderline LDL level. And Indian cardiovascular disease is more to do with innocent, what was once known as innocent triglyceride level. And insulin resistance in our country is more prevalent than what we know of. And exercise definitely plays a role in improvement of insulin sensitivity and better uptake of glucose in muscle cells by opening of blood-4 channels. This study showed that even a single session of resistance exercise enhances insulin sensitivity for at least 24 hours in healthy men. Not only that, leisure time running activity also reduces all-cause and cardiovascular mortality risk. PURE study is a landmark trial which was done in all across the world in different income countries like high income, middle income, and low income countries. And it included 130,000 patients. And it showed that increasing physical activity is a simple, widely applicable, low cost global strategy that could decrease cardiovascular risk. And exercise not only helps in attenuation of cardiovascular atherosclerosis, but it also causes regression of the coronary lesion. And striking the balance of moderation is critical to a given patient. Coming to the guidelines, ACCHA guidelines have recommended at least 150 minutes of exercise. That is only 3 hours of exercise per week. So is it not easily acceptable by patient? Just 3 hours of exercise along with 2 days of resistance training per week. Similar has been highlighted by 2020 ESC guidelines, and another 24-hour movement guideline which has been published in Canada has shown that all across age groups, any form of physical activity is encouraged. One size doesn't fit all. So I'll not end my discussion with just exercise. We have to give one more solution and many more solutions to our patients. And yoga is one such solution which we can recommend to our patient. And we have realized the importance of yoga during COVID pandemic. Not only that, Yoga Care trial is a landmark trial which has emphasized the importance of culturally acceptable cardiac rehabilitation program for the patient. And I would like
time is over.
Yes, just few more slides. The more you can give the choice to a patient, more it is easy to sustain the exercise. In this meta-analysis, it has shown that when we compare yoga with exercise, yoga definitely plays a favorable role in control of LDL as well as triglycerides. Coming to an extension of yoga, how we breathe is also important in how we burn the fat. And when we have a better oxygenation and better removal of carbon dioxide from our body, we get definite benefit by doing deep breathing techniques. The studies are limited, but they are definitely encouraging. Not only that, we have to eat the right kind of food at the right time. That means we can advise a patient to have a heavy breakfast and a lighter dinner, which is in sync with Ayurvedic Indian clock. So with due respect to both the speakers, I would end my discussion by saying that I will strongly recommend physical activity in my patient because it is more acceptable. It will improve the quality and life expectancy of my patient. It is acceptable and cost effective as compared to Mediterranean diet and less traumatic psychologically as compared to modified Indian diet. Thank you for your patient attention.
Thank you, Dr. Shilpi, for a very good presentations. Now the discussion, we will start with discussion.
Yeah, before anybody else can ask, my question to all three speakers, do you think that the Indian modification of a healthy diet is nothing but Mediterranean diet without wine and fish. Shweta, you can unmute. We can't listen to you.
Yes, absolutely. I believe so. Mediterranean diet is exactly nothing but a balanced diet where the only focus is on olive oil and fish. We can definitely replace that with our Indian meals.
So basically, Aryans did not just bring the racial genes to India, but they probably also brought the diet to India. So we actually probably have a common root in our dietary manifestation. Dr. Erin, your comments on that?
Well, I just want to congratulate all the speakers on some great talks. And of course, I'm a very exercise enthusiast, as you heard. And so I agree completely with Dr. Shilpi. I always want to say, I don't think it is an either or. I see it as a both, Mediterranean style diet and physical activity and yoga and lifestyle. I also co-authored the AHA guidelines on meditation. We found a lot of cardiovascular benefits. So I don't see it as an either or. I think we need to do it all. And so I would encourage both. But I do think in terms of controlling lipids per se. So of course, exercise has overall cardiovascular benefit, improving overall cardiovascular health. It is really hard though to change at least LDL cholesterol entirely by exercise without any dietary change. Certainly, exercise and weight loss will impact triglycerides and HDL. But LDL is impacted much more by dietary changes than by exercise. So I really think you need to do both, and it's not an either or.
Over to Chairperson.
Can I make a comment? Yeah, I think not only to this patient, but to all Indian patients, we have to do a recipe of the Mediterranean recipe in an Indian format and an exercise that Dr. Shilpi Mohan has suggested. And when the Mediterranean diet has come from Italy, that doesn't mean that all Italian diet is Mediterranean. That is what we have to be very clear about it, because we feel that anything that is Italian is Mediterranean. That's not true, because our patients are, most of them, eating Italian pizza under the impression that it could be in the Mediterranean diet. That's not true. And some of the fruits, we have to go for the seasonal fruits rather than the avocado or whatever that is suggested in the Mediterranean diet. But otherwise, I think it's a package that is Mediterranean diet with an Indian recipe.
May I ask a question? Hello.
Yes, sir.
May I ask Kamal, is there any method of walking? There are so many patients who walk for 1 hour every day, but it's a leisure walk. Would it help them anyway?
Shilpi, would you like to answer that?
Yeah, the studies have shown that even slight amount of physical activity is going to help. So earlier it was thought it is all and none principle, and that is why most of the patients, they get demotivated because they feel they'll not reach the optimum level. But if you look at the Canadian 24-hour guidelines, it has shown that any level of physical activity, even when you're sitting for 3 hours, even if you stand in between or go around in your house and take a walk, then also it is going to benefit more than just sitting and having a leisure time for more than 3 hours. So any kind of physical activity is encouraged. And I would definitely agree with other speakers that only diet will not play a role. You have to have a balance, have a reduction in diet, have a measured diet at the right time, as well as continue with your exercise regime as much as possible so as to get the maximum benefit.
I think it
But
also gets from the... yeah, Dr. Erin, please go ahead. Sorry.
I was going to say that
Shilpi,
most of the cardiovascular benefits are from a modern intensity activity.
Exactly.
So 4 to 6 METs. So you don't have to do the vigorous activity to achieve the cardiometabolic effects. Obviously, vigorous activity may help with fitness, but really you get all your metabolic effects with moderate intensity activity, which brisk walking, so picking up the walking at a little bit of a brisk pace falls as a moderate intensity activity. And most patients can do brisk walking. But I completely agree that any activity, including light activity, less than 4 METs is better than being sedentary. So all activity counts. But if your patients are already walking, I would encourage them to try to pick up the pace a little bit and get into that moderate intensity range, and they can get additional cardiometabolic benefits. But
basically, what I recommend to my client in terms of exercise is I just ask them to walk for 5 kilometers in an hour. So that would definitely be an intense brisk walk, which will definitely help them work on their fat levels.
One of the major difference is that in the Mediterranean diet, less stress is given to the dairy products, and that is what our patients consumes a lot. So that may be replaced by the legumes and pulses to replace the protein part.
Definitely, yes.
Given the expanse, can I? Given the expanse of the Indian subcontinent and the diversifications in terms of geographical, social, economical, and cultural parameters, I think we cannot apply one plan to the entire subcontinent. And in this session also, I would like to know how far have we addressed the rural Indian? Because the rural Indians, they constitute approx 65% of the population. And probably the logistics are very, very different for the rural Indians, or even for that matter, the rural to urban migrants.
Yeah, so basically, as I stated in my this thing, why Mediterranean could not be our we cannot adjust is one of the reasons. It is not cost effective. The olive oil that we get in India is very costly, so we cannot use olive oil. Plus, the cooking process that we adhere to in India is not acceptable with olive oil. So yes.
Dr. Nikhila?
Yeah, a few things I would like to add here is that basically compliance is what matters at every level, whatever things we have discussed. This is a young male, what we have discussed, 33 years. He has a long life expectancy. So compliance at every level, the drug, the diet, the exercise, everything is going to matter. And if we see our own, I mean, the people whom we are, I mean, including in this CARDIOCON, I mean, majority of the people will not be following any of the diets. None of them will be following any exercise patterns. Even I am not doing that, even being a chairperson. But the compliance actually should matter at every level.
It's all about the biological clock that I feel. The biological clock is almost, I always tell to my client that the biological clock and the career clock are exactly opposite. So that's the reason why we all fall into this lifestyle disease cycle.
Right.
I
And
think
this is why I really
point-
think balanced diet is so important. So I think compliance and adherence is absolutely a key issue, and which is why I think some of the fad diets that are emerging, you know, at least in my part of the world, these intermittent fasting, these keto, these sometimes these ones are there. You might have very short-term weight loss and effects, but I think that anything that's too difficult to follow is really going to be hard. You want to teach people to eat well and eat healthy for a lifetime, and so it's all about balance. And all of these healthy diet plans, you know, they have more in common than they have different in terms of what is considered a healthy diet plan.
I think from the London bus driver study, which was probably the first study to tell us about the differences of the events that happen in the bus driver versus the conductors, actually told us that when you're working for some minutes in whatever way of activity may be important. And I think that's what Dr. Shilpi was trying to point out in the Canadian guidelines. So, I mean, doing something is always better than doing nothing. I mean, the way a lot of cardiologists, a lot of physicians in this part of the world do is not to take flights. They would usually climb the stairs, or like in my own office, I would keep the echo the farthest from my consulting chamber, so that between the two patients, if I have to go for an echo, I usually would walk that distance. And between 10 echoes, I would have walked maybe a mile. So I think small kind of modifications probably have to come with the COVID kind of era, where we need to modify when we have become more sedentary than we otherwise were. We were actually last year in CARDIOCON running between the halls, and today I'm sitting on this office and managing 2 halls without moving a minute. So I think we need to be adjusting, evolving, and probably same has to happen with diet and exercise as well.
Right.
So we can have a last word from the chair and each speaker, please. Dr. Erin first.
No, I think we've covered all the points I wanted to make across. And really, it's a multi-pronged approach. This is a very high-risk patient for recurrent events, so he needs everything, including, you know, aggressive medical management, LDL lowering, diet, lifestyle, stress reduction. You know, he needs a comprehensive approach. And I'm really pleased to be part of your session today. Thank you.
Thank you, Dr. Shweta.
Yeah, so basically, as Dr. Erin said, most of it has been covered, but then this patient definitely needs a combination of a biological clock management with a balanced diet and a proper exercise schedule with the proper sleep time and waking up time. And yes, stress management is also one of the area where the patient should be focusing, and yoga is the best thing to do that.
Dr. Shilpi.
Yeah, first of all, I would like to thank you because you have done a wonderful session and you are very dynamic. You don't need any guidelines for anything. And I would definitely
Not the same,
recommend.
Shilpi. It's been pleasure knowing you. We were doing residency at the same time. We were at a time. You were in Delhi and I was doing it in Ahmedabad. That's the only difference. Good to know you.
Yeah.
To have you. It's good that you connected from all the way from Kyrgyzstan. She's right now at Bishkek and she's connected from there. Shilpi, and she's been into lifestyle. Actually, all the chairpersons that we have today, Dr. Shivani, Dr. Dhaval Doshi, he's an interventional cardiologist who's more into holistic preventive cardiology. So always a pleasure. Dr. Dhaval.
Thank you, sir.
Yeah, I would only add one point. The patient counseling is most important, and repeated counseling to the patient and keeping him motivated because he has a long way to go. Thank you.
Dr. Dhaval, Dr. Nikhila.
Thank you, sir. And I would like to congratulate you. It was a really great, all the sessions were really nice. And I would like to congratulate all the speakers, Dr. Erin, Dr. Shilpi, and Dr. Shweta. All the sessions were informative and we have got good information about Mediterranean diet, about role of exercise in our day-to-day life, and also a bit of indigenous modification to that. So in all, I would like to summarize and say that basically balanced diet and with compliance actually should matter everything. And very nicely told by Dr. Shilpi that we have to counsel them. That is actually is going to make a big difference. If we have to follow something or make them follow, counseling is actually going to make a lot of differences. So let us make a lot of differences in people's life, and congratulations everyone. Good night.
Good night.
Good night. Thank you. Thank you very much. Thank you,
Thank you.
Dr. Erin, Dr. Shilpi, Dr. Shweta, all the speakers.
Thank you.
Thank you, sir.
All chairpersons
Thank
and
you.
attendees. Thank you very much. This was the last session of the day, and we'll be back tomorrow morning, 10:30 Indian Standard Time, for the next session on both the halls. Thank you very much. Thank you, everyone. Have a good night. Bye.
Thank you.
Bye.
Good night.